Hi, my name's Professor Karen Smith, and it's my absolute pleasure to be presenting at the European Resuscitation Council conference this year in the survivorship session part 2, talking around return to work after cardiac arrest. It's great to see that survivorship is on the agenda in the conference, and then we're involving survivors more and more in these events and part of these discussions. I'm the Director of Centre for Research and Evaluation at Ambulance Victoria in Australia, and I'm also the Chair of the Victorian Ambulance Cardiac Arrest Registry. And like I said, it's my great pleasure to be discussing with you return to work post-cardiac arrest. So survivorship is complex and acknowledges the complex emotional, physical, cognitive, social and economic challenges associated with treatment and recovery. And returning to work is a real part of that. So work is a key determinant of health and well-being, and it plays a really important role in positive physical and mental health, an individual's identity, purpose and their position in society. And return to work following illness has been shown to be associated with improved health status and recovery. So it's really complex and entwined in a person's position in society, how they see their identity and their quality of life. And the relationship between quality of life and return to work is complex. But this issue has seldomly been examined or explored for cardiac arrest survivors. And return to work for cardiac arrest survivors might be indicative of the individual's capability to maintain their pre-arrest societal function and be seen as a positive outcome post-cardiac arrest. So there have been a number of studies examining this. I'm not discussing all of them, but a key few. Most of them have been small, however, and have looked at return to work in various cohorts and also at various time points. So there was a good study that did come out of the Danish Cardiac Arrest Registry, which was published in Circulation in 2015. Now, they looked at patients arresting from 2001 to 2011. Of the almost 4,500 patients who were employed prior to their cardiac arrest, aged from 18 to 65, they had 796 survivors. And when they followed up those survivors, they saw that almost 77% had returned to work, and the median time to return to work was 4 months post-arrest. And when they followed them up further, they saw that the median time that survivors stayed in their job was 3 years post-arrest. And they looked at predictors of returning to work, adjusting for the factors that you would feel that would influence that, and the independent predictors that they demonstrated with their study was arresting in the latter years of the study. So that's probably indicative of better pre-hospital care, better hospital care, resulting in better survivorship and a higher probability of returning to work. Males were much more likely to return to work, and remember this is after adjusting for other factors. So that's something that has sort of fairly consistently come up in the literature, and something that definitely needs exploring further. Not surprisingly, younger age was associated with returning to work, and also whether the arrest was both witnessed by a bystander and also received bystander CPR. So again, indicative of that early intervention, resulting in better outcomes and resulting in better long-term outcomes for patients. There was another great study as part of the targeted temperature management trial, and this was headed up by Gisela, who's also presenting in the survivorship sessions. So any questions about this study, I encourage you to approach Gisela. So they took the patients, a cohort of the patients that had been enrolled in this trial, randomised controlled trial, which was examining, targeted temperature management after cardiac arrest. And they looked at 287 cardiac arrest survivors, and they matched those to 119 heart attack or STEMI controls. And they followed up patients at 180 days post-arrest or post-STEMI or post-arrest, and did a barrage of tests on participants. And they saw that at this time point, 27% of cardiac arrest survivors versus only 7% of heart attack survivors were still on sick leave post their event. And this is for participants that had been working prior to their event. So on the flip side of this, we're seeing sort of 73% of cardiac arrest survivors versus 93% of heart attack survivors returning to work at that time point. And when they looked at the cardiac arrest survivors in particular, those with cognitive impairment were 3 times more likely, after adjusting for other factors, to be on sick leave at this time point, so have not returned to work, than those without. And when they looked at other factors that were contributing to a lower participation in the workforce, they saw things like depression, restricted mobility, memory impairment, novel problem-solving difficulties, fatigue, and slower processing speed. And then if we look at a study that was published in Resuscitation in 2018, which looked at survivors from cardiac arrest from a particular ICU in Paris, aged from 18 to 65, and for patients who were arrested between 2000 and 2013. So they had 115 survivors, of which only 62% had returned to work. And this was on average almost 2 years post the cardiac arrest, which is an incredibly long time period. However, most did return to the same job, 75%. And when they examined in a multivariable model the factors that look like they're significantly associated with returning to work, again they saw younger age, which is not surprising, but also patients who were in jobs that were sort of managerial or professional versus technical occupations, and also whether the arrest actually occurred in the workplace was predictive of patients returning. So this brings me to our study using the Victorian Ambulance Cardiac Arrest Registry, which was published in Resuscitation this year. So to give you a bit of a background around VACAR, the Cardiac Arrest Registry, it's been running since 1999 and has around 120,000 patients currently in it. In Victoria, we're serviced by one ambulance service, Ambulance Victoria, and we see around 6,500 cardiac arrest patients per year. And the registry since 2010 has been following up all adult patients who survived their arrest, so 18 years and older. We administer a number of tools at the 12-month follow-up. So we look at functional outcome using the Glasgow Outcome Scale. We look at quality of life using the short form 12. And we also look at quality of life using the EQ5D, which is a generic measure of quality of life, looking at 5 domains. And we also ask some additional questions on residential status, whether they're living at home, whether they're living at home without care, and employment status post-arrest. And for this particular study, we only looked at patients who were working prior to their cardiac arrest. We also did a small, more detailed follow-up of a cohort of survivors who arrested in just one quarter of 2017, and this involved a more detailed return to work interview, asking about barriers to work, returning to work, and how the workforce had accommodated their return. And we looked at individual predictors of whether a patient would return to work in 3 different models. Because of the relationship between quality of life and return to work, a higher quality of life is more likely to result in a patient returning to work, and return to work is more likely to result in a higher quality of life. The complexity of that interaction makes it difficult to tease out some elements. So we used 3 different models. One model where we didn't include quality of life, one model where we included the EQ5D index score, which is a score that can be calculated with sort of perfect recovery being a score of 1, and another model that included the 5 domains of the EQ5D, which is mobility, self-care, anxiety, pain, and depression. So we sort of teased it out by including all 3 models. So what we saw over the time period, Ambulance Victoria went to over 17,000 cardiac arrests, of which 2,328 survived a hospital discharge, and the 12-month interview was, and I must say these were adult cardiac arrests, the 12-month interview was done on 1,394 patients and 371 proxies. So where a patient is either unavailable or not inclined to, or there's barriers such as language barriers, or they're unable to do the 12-month interview, we as much as possible try and do the interview with a proxy. So we can see that there, of that cohort, 886 were working prior and 650, which is 73%, had returned to work at the 12-month time period. And then if we look at the smaller cohort that we did a more detailed interview for, there were 77 potential eligible patients, but 2 had died at the 12-month period, 2 had sort of retired or they were unemployed. 29 had retired or they were unemployed prior. We had some loss to follow up, and we had 2 refusals. So we interviewed 23 patients, 20 of which had returned to work and 3 of which did not. So what we see from our cohort for this particular study, and remember these are all patients who had been working prior to their arrest, so some of their characteristics can be a bit different from the broader arrest population. For example, the median age of these participants was 54, 85% of them were male, and 82% of them had been working full-time prior to their cardiac arrest. And as I said, we saw a return to work rate of 73% in this cohort, 88% to the same role and 89% to the same organisation. And when we asked the patients about their quality of life according to the EQ5D verbal analogue scale, which is asking patients to rate sort of their quality from a score of sort of 1 to 100, the participants rated at the 12 months, their quality of life at a score of 80, and the median score prior to the arrest was 85. And we also looked at what's called the standardised mean difference with the SF12. So the SF12 can be broken into a physical component score and a mental component score. And you can look at how different your participants are from their age and gender peers in the population by looking, doing what's called a standardised mean difference, and that looks at how far away they are from the mean of the population norms. And a score of 0.8 is considered to sort of be clinically significant. And if you see how they compared to their peers with the physical component score, the standardised mean difference was only 0.06, and with the mental component score, it was only 0.07. So this is reflective of, for this score in particular, quite good quality of life measures at the 12-month mark. And so when we looked at our models, we saw that the independent predictors of return to work. So the increased likelihood was, again, males, and this is after adjusting for multiple factors. So males were 80% more likely to return to work than females, much more likely to return to work if you're witness to arrest by a paramedic, and this is probably indicative of very rapid resuscitation and therefore much better neurological outcomes. And if you were discharged directly home as opposed to rehabilitation or in some cases a nursing home. So again, probably a surrogate marker for sort of the quality of the outcome at the hospital discharge point. Things that were likely to decrease your odds of returning to work include arresting due to traumatic causes. Now, this may be reflective of injuries that are still being recovered from or other factors. The number in our cohort of traumatic cardiac arrest survivors is so small that we would need a much longer time period to really tease this out. Not surprisingly, increasing age decreased the probability of returning to work, and employment in trade or labour compared to a professional or managerial role significantly decreased the likelihood of returning to work. And so when we look at, and one thing that was interesting was neither workload prior or education level were significantly associated with returning to work. And when we looked at models including quality of life, adjusting for quality of life, the variables that I've just described as being independently associated with returning to work didn't change when we put quality of life in the model, but quality of life itself, or the EQ5D that we put in the model, was significantly associated with returning to work. So if you had an EQ5D of 1, then you were almost 4 times more likely to return to work than patients with lower EQ5Ds. And when we looked at putting the various domains, EQ5D domains into the model, if patients had reported no problems with mobility, self-care, anxiety or activities, daily activities, they were more likely to return to work than patients who reported some or severe problems. But pain was the one EQ5D domain that was not associated with any return to work factors in the model. So when we looked at the detailed components, so the study, the more detailed interview offered to potentially 77 and the 23 patients, so 87% had returned to work and 80% to the same role. The median time to return to work was 7 weeks, and 85% said that they were offered some sort of flexible work arrangement. So this might have been fewer shifts, shorter shifts, role sharing, less physical duties, or reduced workload. But even though the majority returned to work, 85% of the cohort reported some sort of barrier, and professionals were more likely to report no difficulties. Fatigue came up as one of the most frequently reported factors, and this has been seen in other research and is something that we can really think about trying to mitigate or ameliorate or address through various rehabilitation programs that can really help survivors deal with that then may help with return to work. And not surprisingly, for some just medical restrictions like loss of a licence post critical illness meant that they couldn't return to work. So if we look at the percentage of people reporting barriers to return to work by the type of occupation that they're in, really the sort of trades and production, transport, sales were much more likely to report some sort of barrier, and with trades, 100% of tradespeople and people in sort of service and sales reporting some sort of barrier to returning to work, compared to sort of the professionals and managerial sort of roles where lower percentages reported barriers. And when we look at the specific barriers that people reported, again, like I said, fatigue was a really big one that came up, as was, as was cognitive impairment. So not surprising, these issues or barriers in patients that both return to work and that don't return to work. So what can we conclude from this? So there are very few studies to date that focus on this specific issue. Most of them are small, so have the issues associated with small sample sizes and some other quality issues such as, varying time points, various levels of follow-up, various lengths of follow-up. But what we can see from the study is that we can see about 62 to 70% of patients, cardiac arrest survivors, do return to work at various time intervals. The predictors of return to work often align with the predictors of survival, which is not surprising. Barriers include fatigue, cognitive impairment, and medical restrictions. And men are much more likely to return to work than women, and this is after adjusting for a whole lot of other factors. And it may be in some ways due to the fact that men may be the main income earners in the family, and so the imperative on them to return to work is stronger. But it really needs more exploration, because we see this issue in other areas of cardiac arrest survivorship. We just published last year that when we look at our quality of life in male survivors versus female survivors, after adjusting for multiple factors, females have a lower quality of life. And it's been well reported in various care trajectories that women receive less aggressive sort of resuscitation and care and post-resuscitation care than men. So this inequity that is on sort of all levels of the pathway really needs more exploration and targeted interventions. The interplay between quality of life and return to work is not well understood, and it's something that still needs quite a bit of work. And we need to look at how some of these common issues that are consistently coming up through these studies, such as fatigue and even mild cognitive impairment, can be addressed through evidence-based rehabilitation pathways. And that evidence-based pathway is still something that we have a lot of work to do on. And also, of course, return to work is not the only measure that we should be looking at. It's one of many. It's significant for a lot of people, but there's also a lot of survivors who weren't working prior, and we need to examine other factors that might show a good quality return to sort of society and immersion into sort of things that were important prior to the cardiac arrest, such as return to important hobbies. And there's obviously still a huge amount of work that needs to be done in this space. So thank you very much for listening, and I hope that you enjoyed this, and hope that there'll be participation in questions when the panel discusses this at the conference.